Bismillah ar-Rahman ar-Rahim. Our lecture today about diuretics. These drugs increase renal excretion of sodium solutes and water, thus increase the volume of urine and often change its pH as well as the ionic composition of urine and blood. That means is not drugs increase the volume of urine as water excretion by the glomeruli, but also increase the solutes, which is sodium mainly here. There are some fluids that or substances increase the volume of urine not considered as diuretics because they not excrete solutes or sodium, but the drugs increase sodium solutes as well as water, so it is called diuretics drugs, which is often change pH of urine as well as the ionic composition of urine and blood. Few points about the physiology of renal mechanism. The GFR or glomerular filtration in 24 hours, as you know, is 180 liters per day, while the volume of urine is 1.5 liters per day. So the rest is reabsorbed by the renal tubules, and the major effect of these drugs diuretic is to inhibit reabsorption of sodium by renal tubules, so that increase sodium excretion, which is combined with water to keep the osmotic balance of the body. The hydrogen ion, important point here, is help in reabsorption of sodium and bicarbonate, that's CO3, and help in ammonium ion excretion. Another point, hydrogen and potassium can exchange with sodium and substitute for each other. This is important point regarding physiology of the nephrons and renal tubules regarding reabsorption of the sodium by renal tubules. That means the hydrogen ion is important for reabsorption of sodium and bicarbonate. The presence of hydrogen will help in absorption of sodium and bicarbonate. And this is also help in ammonium ion excretion. Hydrogen and potassium can exchange, وهذا راح نلاحظه في distal convoluted tubule with sodium. That means الهيدروجين والبوتاسيوم excreted and enhance the absorption of sodium. أو بالعكس according to body needed. يصير excretion for sodium with keeping of potassium and hydrogen ion. According, as we say in the distal convoluted tube, according to the body needed and under hormonal influence مثل ما راح نشوف بالمحاضرة. Regarding the physiology of nephron, مثل ما أخذته بالفسيولوجي إنه at the proximal convoluted tubule 70% of filtered sodium chloride and water are reabsorbed by simple diffusion in such rapidity that to keep the osmotic balance between the intraluminal and interstitial fluids. يعني 70% of filtered sodium مثل ما ذكر 180 liter per day. It will be filtered through the glomeruli. Only the excreted 1.5, so the rest will be reabsorbed. Mainly at the proximal convoluted tubule, in about 70% of filtered sodium, chloride, and water are reabsorbed on such rapidity to keep the osmotic balance between the luminal fluid or intraluminal fluid and the peritubular fluid or interstitial fluid. Number two, in ascending loop of Filli, in this part there is active reabsorption for chloride followed by sodium, and there is no water reabsorption. No water reabsorption. لذلك راح يصير شنو عندنا هنا active reabsorption للكلورايد followed by sodium when there is no water reabsorption in this part. So it is known as diluting segment. يسمونها diluting segment. Why? Because it is reabsorbed actively chloride sodium without water. So it is the make urine hypotonic or hypoosmotic with a diluting segment, diluting urine. So it is called diluting segment of ascending loop of Filli, and in which 20 to 30% of filtered sodium chloride is reabsorbed here, will be reabsorbed. Yes, distal convoluted tubule. At the distal convoluted tubule, sodium is reabsorbed in exchange with potassium and hydrogen, as we said before. but under aldosterone influence. This part is responsible for 5% of filter sodium reabsorption. يعني يصير هنا reabsorption للصوديوم by 5% of filter sodium renal tubule from renal tubule still reabsorption about 5%, but in exchange with what? Potassium and hydrogen under aldosterone influence as we see. Everybody needed for sodium راح يصير الالدوستيرون secreted to reabsorption of sodium and water. And as we know from physiology, it is aldosterone hormone secreted from adrenal cortex in response to hypovolemia or hyponatremia when we need it for water in hypovolemic shock, or there is hyponatremia, decrease in sodium concentration, enhanced excretion, reabsorption of sodium about 5% from distal convoluted tubule in exchange with potassium and hydrogen excretion. Clear? Number 4, add collect which hormone? Antidiuretic hormone, ADH. The presence of ADH, this part going to be more permeable to water. Urine become hypertonic and vice versa. When there is no antidiuretic hormone, the urine will become hypotonic, increase dilution and increase volume of urine in the presence of ADH. This is the physiology of normal physiology. So our aims in our lecture today about the group of diuretic according to their efficacy in excretion of sodium, which is called the natriuretic effect, classified into high efficacy diuretics or high ceiling diuretic, or called also loop diuretics. They are furosemide, ethacrynic acid, البيوميتانide, البيريتانide, التورسيمide. البروتوتايب اللي هو الفوروزامايد اللي هو الاسم التجاري للازكس. البيوميتانايد ايضا الموجود اللي هو البيورينكس ابو 1 ملي جرام. الفروزامايد اللي هو لازكس ابو 40 ملي جرام موجود على شكل تابلت. Ampules, intravenous, intramuscular can be given. Yes, they are called a high loop diuretic. Why? Due to their action on the medullary part of ascending loop of Hilli. الميدولاري بارت اوف ascending loop of the diluting segment اللي حكينا عليها اللي قلنا يصير بها dilution for the urine by active reabsorption of sodium chloride followed by sodium without water. So there is dilution, hypotonic or hypoosmolar urine. Clear? So it is the medullary part of ascending loop يصير inhibition for this reactive active reabsorption of sodium and chloride. So it is also slight on its effect, an effect on the proximal convoluted tubule. Other feature for such a group can work even when the GFR is below 10 mol per minute. Can be work even when the glomerular filtration rate below 10 mol per minute. So it is high efficacy diuretics. أو سميناها because it is work when the GFR below 10 mol per minute. It is called also loop diuretic. Why? Because it is act on medullary part of ascending loop of Hilli. And it is also called the high ceiling diuretic because can excrete, in fact, about 15 to 20% of filtered blood in the renal tubule from sodium. 15 to 20% of filtered sodium will be excreted by high efficacy diuretics, or called loop diuretic or high ceiling diuretics. Inuria is contraindication of this group. Yes, it is, can be work when the GFR below 10 mol per minute, but inuria is contraindication for using a high efficacy diuretic. Different chemically, different agent chemically, but also have similar properties and indication. They are vary in their efficacy also. Mechanism of action مثل ما ذكرنا انه الميجر mechanism or action for diuretic, high efficacy diuretic by inhibit what? Chloride and sodium reabsorption where in the yes, their inhibition or mechanism of action by inhibition active reabsorption of chloride and sodium at the medullary part of ascending loop of Hilli, and this will lead to increased excretion of both of them in urine, which is usually combined by water. Potassium is also excreted, and this is important point. Why? And lead to hypokalemia because large amount of sodium is subjected to the distal tubule where it has more chance to be exchanged with potassium. And this loss of potassium may be lead to hypokalemia adverse effect can be corrected either by using potassium supplement or using low efficacy diuretic البوتاسيوم sparing diuretics مثل ما راح نجي ناخذها ونشوف ايضا الكومبينيشن that retain potassium to the body according to their action. Then the major mechanism of action of the high efficacy diuretic by inhibit the active reabsorption of chloride sodium at the medullary part of ascending lobe of the lead, lead to an increased excretion of sodium chloride associated combined with water, and there is loss for potassium, lead to hypokalemia. Lead to hypokalemia can be corrected either by using potassium supplement or by using low efficacy diuretics, which is act as potassium sparing diuretics. Onset of action of a high efficacy diuretic when given intravenously within 2 to 10 minutes only. Rapid onset of action and about 1 hour if given orally. With the duration of action may persist for 4 to 6 hours. So onset of action when giving intravenously or parenterally, intravenously, yes, is rapid onset and we need it for emergency condition. Emergency condition when we need it for induced diuresis as number one, acute pulmonary edema. The clinical indication where number one, in acute pulmonary edema. Emergency condition we need it for inducing diuresis rapidly within 2 to 10 minutes if giving intravenously. Number one, in acute pulmonary edema due to congestive heart failure and relief of clinically from practice relief or occur relief of shortness of breath, improving condition of patient notes occur before induced the diuresis, and this is may give a hint for effect of a high efficacy diuretic on the blood vessels dilatation rather than by induced diuresis on the renal tubule. Yes. Number two, hypertensive crisis, severe hypertension. Number three, all cases of heart failure, particularly refractory heart failure, another indication. Chronic renal failure associated with edema, indication for first indication for using of loop diuretics. Refractory edema, nephrotic syndrome, oliguric state, decrease in volume, urine volume to protect kidneys from development acute renal failure. And as we say, should not use, as we say, in urea. Promote calcium excretion, important point here. Calcium excretion enhanced by using high efficacy diuretics. So can be using in some cases with hypercalcemia with normal saline to decrease calcium, but not to state of hypocalcemia. In some cases of drug toxicity by induce forced alkaline diuresis, to eliminate some drugs from prevent their elimination or reabsorption by the renal tubules. So this is the most important clinical indication of high efficacy diuretic, acute pulmonary edema, hypertensive crisis in all cases of heart failure, chronic renal failure with edema, refractory edema, nephrotic syndrome, oliguric state to prevent development acute renal failure, promote calcium excretion, that means in some cases of hypercalcemia with normal saline, and to treat some drug toxicity by induced forced alkaline diuresis. Contraindication, as we see in patients with anuria or those with hypokalemia. Adverse effect of high efficacy diuretic, number one, metabolic alkalosis. Why it is occur? Result as chloride loss relatively excreted more than bicarbonate. Due to loss of chloride more than bicarbonate to alkaline. Number one. Number two, hyperuria occur because the high efficacy diuretic and uric acid have the same secretory mechanism or renal tubules. So there's a competition on the same secretory mechanism. So number two, second adverse effect, hyperuricemia, because high efficacy diuretics and uric acid have the same secretory mechanism or renal tubule. There is number three, decrease in carbohydrate tolerance with increase blood glucose and hyperglycemia. Number four, hypokalemia, as we say, which is less serious than produced by the second group of diuretic, which is called the moderate efficacy diuretics, because of their short duration of action in comparison with moderate efficacy diuretic. بمعنى أنه duration of action of moderate efficacy diuretic is longer when comparison with the low high efficacy diuretic. So risk of hypokalemia more serious with the moderate efficacy than with the high efficacy. Number five, might cause renal interstitial nephritis and lead to reversible renal failure. Deafness or ototoxicity, which is transient with the furosemide, infrequent with the bumetanide, and may be permanent with the ethacrynic acid. Another adverse effect, GIT disturbances. GIT disturbances with or without bleeding. If it is given to patients, as we say, with ascites, may lead to hepatic coma or hepatic encephalopathy, and probably hepatic renal syndrome because liver cell necrosis. If there is hypokalemia, so should be monitoring for level of plasma potassium. Hypomagnesemia, there is loss for magnesium also. Hypotension, if there is severe induced diuresis, skin rash and paresthesia. Skin rash and paresthesia. This is a major or main more common adverse effect associated with use of high efficacy diuretics. These drugs, as we see, inhibit why it is high efficacy diuretic, because as ability to induce or inhibit 15 to 20% of filter load. The duration of action, as we say, about 4 to 6 hours, and onset of action is rapid when giving intravenously within 2 to 10 minutes, and orally about 1 hour. Another group, moderate efficacy diuretic. This group of drugs classified into or into two types of drugs, two groups of drugs, represented by thiazide drugs that include the prototype, اللي هو الكلوروثيازide, another الهيدروكلورثيازide, البندروفلوميثيازide, وcyclobenthazide, and other drugs. Another group here, drugs related to the thiazide in mode of action and duration in the diuretic effect, like chlorthalidone, metolazone, indapamides, and others. What about this group, moderate efficacy diuretics? These drugs, effective orally, take 1 to 3 weeks to produce a stable reduction in blood pressure, except prolonged biological half-life, about 40 hours. Due to this prolonged biological half-life, قلنا risk of hypokalemia associated with this group of moderate efficacy diuretic, which represent by thiazide drugs, more serious than produced with a high efficacy or loop diuretics, to long biological half-life. هناك قلنا duration of action for a loop diuretic about 4 to 6 hours, while for a thiazide group 40 hours. They are represented by thiazide group. They inhibit only 5 to 10% of filter flow, so it is called moderate efficacy, not like high efficacy diuretic has ability to secrete 15 to 20% of filter load. They won't work or don't work if the GFR is below 20 mol per minute. Difference point between the high efficacy, they won't work if the GFR below 20 mol per minute. بينما قلنا بالhigh efficacy, even when the GFR less than 10 mol per minute can be worked. Their site of action هناك قلنا الميدولاري part of ascending lobe of هنا يكون الاكشن بالاضافه للبروكسيمال convoluted tubule. هنا الاكشن يكون على الcortical diluting segment mainly and have some effect on the distal convoluted tubule. Thiazide are sulfonamide derivative. and are related structurally to the carbonic anhydrase. Can inhibit carbonic anhydrase because it is related to the sulfonamide. And for this reason, mechanism of its action represented by two forms or two actions. First one, carbonic anhydrase inhibitor. Carbonic anhydrase inhibitor. Inhibit for this enzyme. Why? Because it is structurally related to the sulfonamide that has ability to inhibit the carbonic anhydrase. وinhibit carbonic anhydrase lead to decreased concentration of what? الهيدروجين ions. وقلنا بداية المحاضرة أنه الهيدروجين ion important for reabsorption of sodium. لذلك ما عندي هيدروجين ماكو absorption للصوديوم lead to enhance excretion of sodium by this way by inhibit carbonic anhydrase enzyme. Number two, direct inhibition for sodium reabsorption like high efficacy diuretic. There is direct inhibition for active reabsorption of chloride brought by sodium at the diluting segment of loop of Willi, but cortical part lead to an increased excretion sodium chloride in urine with potassium due to subject high amount of sodium in the distal convoluted tubule has more chance to be exchanged under influence of aldosterone hormone with the potassium. So there is loss for sodium, chloride, potassium in the same mechanism of action like loop diuretics, beside also carbonic anhydrase inhibitor as we see. They have antihypertensive action partly due to volume of urine lost lead to decreased cardiac output and another part due to effect on the blood vessels because non-diuretic thiazide which is called diazoxide is act as antihypertensive agent بمعنى انه اكو drugs related to the thiazide but it is non-diuretic thiazide. Non-diuretic structurally thiazide property pharmacological action structure but non-diuretic thiazide that means induce hypotension or it can be using for as antihypertensive agent not by induced diuresis rather than by induced vasodilatation. So it is called non-diuretic thiazide like diazoxide. And this gives a hint of thiazide drugs to act as smooth muscle relaxation of the blood vessels beside induce of diuresis to treated hypertension. To treat hypertension. So the clinical uses or indication of the moderate efficacy diuretics. إذا قلنا هنا قبل الكلينيكال indication إنه moderate why it is moderate because they can excrete only 5 to 10% of filter dose of sodium. بينما هناك بالهاي efficacy قلنا 15 to 20% of filter sodium inhibition excretion. Number two, high efficacy diuretic can work if the GFR below 10 mol per minute. هنا moderate efficacy cannot work if the GFR below 20 mol per minute. Site of action high efficacy بالmedullary part of ascending lobe of Willi هناك يكون بالcortical part of lobe of Willi بالإضافة للdistal convoluted tubule. Risk of hypokalemia more serious with the moderate efficacy rather than with the high efficacy due to long duration of action when comparison with the high efficacy تكون short duration 4 to 6 hours بينما moderate can be reached for 40 hours. And other adverse clinical uses. Number one, chronic renal failure. ذكرنا انه وحده من indication of loop diuretic here for a chronic renal failure with edema. يعني can be treated firstly by loop diuretic if you can give الميتولازون اللي هو ذكرناه كexample for النن أو drugs related to the thiazide. الميتولازون with loop diuretic can be added with loop diuretic to control edema of chronic renal failure. Number two, edema due to chronic hepatic diseases. But if there is hepatic hypokalemia, if there is hypokalemia, may worsening and precipitating encephalopathy. As we said, due to hepatic liver necrosis or hepatic necrosis or liver necrosis. Number three, hypertension. either used alone or in combination with other antihypertensive agents. وقلنا هنا يكون تأثير المودريت efficacy diuretic in control mild to moderate hypertension more effective than الهاي efficacy الهاي or severe hypertension اللي هو emergency condition like hypertensive crisis when we need it for quick or rapid onset for induced dialysis should be used what الهاي efficacy diuretic because onset of action within 2 to 10 minutes مثل ما ذكرنا if using intravenously لكنه من نقدر نستخدم لكنه الاكشن duration of action orally بالنسبه للمودريت efficacy may take 2 hours. Yes, نستخدمها for control mild to moderate hypertension either alone or in combination with other antihypertensive agent to control mild to moderate hypertension rather than severe hypertension or hypertensive crisis, which is treated immediately by high efficacy diuretics. Number 4, hypocalciuric. يعني لما يكون concentration of calcium ions in the urine is high and this is lead to colicky pain due to قد يكون sometimes idiopathic hypercalciuria, idiopathic hypercalciuria. So to treat it, why? Because decreased excretion of calcium. Moderate efficacy or thiazide lead to decreased excretion of calcium in urine. So it is useful to treat it idiopathic hypercalciuria by decreased excretion or secretion calcium in urine. بينما ذكرنا عن اللوب diuretic enhance excretion of calcium and can be used for treatment some cases of hypercalcemia with normal saline. Number 5, nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus. نقصد هنا يكون عندنا two types بالفسيولوجيا أخذناها either central or pituitary type or peripheral or nephrogenic types for absence of the antidiuretic hormone. Yes, nephrogenic that means it is produced from posterior pituitary gland, the antidiuretic hormone ADH, whether its receptor in the collecting tubules and they not response for its presence by increased permeability of these ducts and the tubules for water and thus lead to polyuria, increased volume of urine due to defect in the receptor in the kidneys, renal tubules and renal ducts. يسمونه بالنفروجينيك insipidus. Thiazide have a unique ability to decrease volume of urine and hyperosmolar urine. That means can reduce volume of urine from 12 liters to 3 liters only by a unique ability. نعرف عنه هو diuretics لكن هنا الاكشن مالته to decrease volume of urine in case of nephrogenic diabetes insipidus. So the clinical uses of a moderate efficacy diuretics, the thiazide group, which represents Y thiazide group, as we see for edema of chronic renal failure, treated firstly by loop diuretic if fail to control on it, added in metolazone اللي هو drugs related to the thiazide. Number 2, edema of chronic hepatic diseases unless there is hypokalemia as lead to hepatic encephalopathy and hepatic renal shutdown. Number 3, hypertension either alone or in combination with other antihypertensive drugs for a mild and a moderate type of hypertension. Idiopathic hypercalciuria. Idiopathic also can be used for a treatment. Idiopathic hypercalciuria. Why? Because it is decreased secretion of calcium in urine. Not like high efficacy مثل ما ذكرنا that increase enhance excretion of calcium and can be used for treatment as we see some cases of hypercalcemia but not to state of hypocalcemia. Number 5, unique features by in nephrogenic diabetes insipidus to decrease urine of volume in this condition from 12 liters to 3 liters only. What are the adverse effects associated with the moderate efficacy diuretics? Similar for the high efficacy diuretic, hypokalemia, but hypokalemia more serious in the moderate efficacy than thiazide group than in high efficacy or loop diuretic. Why? More serious because duration of action is longer here, as we see, may persist for 40 hours, while shorter duration 4 to 6 hours for loop diuretics. Hyperuricemia, the same for high efficacy with attacks, precipitate gouty attacks, because the secretory mechanism also for moderate efficacy or thiazide is the same for uric acid. Hyperglycemia due to decreased carbohydrate tolerance and an increase in the glucose level in the blood. Hypercalcemia due to decreased calcium secretion in urine. Hyperlipidemia, because thiazide can cause 5 to 15% increase of patient using of thiazide drugs and increase serum cholesterol. Hyperlipidemia with thrombocytopenic purpura and other hypersensitive reaction. So there is hyperuricemia, hyperglycemia, hypercalcemia, hyperlipidemia with hypokalemia and thrombocytopenic purpura. Chlorothiazide, as the prototype for a thiazide drug active orally, was capable for affecting severe edema of liver cirrhosis and congestive heart failure with minimum side effect, giving once daily at morning to control edema of liver cirrhosis and congestive heart failure. Chlorothiazide, with the duration of action, as we see, about 12 hours, while chlorthalidone, drugs related to the thiazide with the metolazone, is then thiazide derivative often used in treatment hypertension through single dose per day. Duration of action in an total 48 hours. Metolazone, it is more potent than thiazide, and unlike thiazide can advance renal failure. يعني احنا ذكرنا على مجموعة الثيازايد أو المودريت efficacy diuretics not work if the GFR below 20 ml per minute unless or except metolazone that can be that can be excretion of the sodium in advanced renal failure. So the low efficacy, what about the low efficacy diuretic? They are also, it is low efficacy because it has ability to excrete only 5% of filtered sodium in renal tubule. So it is called low efficacy diuretics. The site of its action were in the distal convoluted tubule with effect on the collecting tubule and collecting ducts. They call potassium conserving or potassium retaining or potassium sparing diuretics lead to an increased excretion only 5% of filtered sodium, site of its action on the distal convoluted tubule mainly. Some classified into this group, low efficacy, this group classified into aldosterone antagonist and inhibit sodium renal sodium channels. الاسبيرينولاكتون اللي هو الالديكتون اسمه التجاري ابو 25 ملي جرام 50 ملي جرام 100 ملي جرام اسبيرينولاكتون it is competitive aldosterone antagonist. While aldosterone, non-aldosterone hormone secreted from adrenal cortex, as you know, in response to hypovolemic shock or hyponatremia. The site of its action on the distal convoluted tubule. If body needed for sodium in distal condition, there is reabsorption for sodium from renal tubule, from distal convoluted tubule, in exchange with excretion of potassium and hydrogen ion. Yes, so spironolactone competitive aldosterone antagonist, the true aldosterone with بالبوتاسيوم conserving or sparing of potassium in our body with enhanced excretion, as we say, about 5% of filtered sodium. So it is called a true aldosterone antagonist. This compete with aldosterone receptor in the distal convoluted tubule and reverse its action, physiological action. Need to enhance, as we see, sodium about 5% with conserving potassium and hydrogen in our body. Spironolactone absorbed orally, strongly bound to plasma protein and rapidly converted metabolism in the liver and converted to active metabolite canrenone. Canrenone. There is another drug within spironolactone, eplerenone, also have a less adverse effect than spironolactone, can be using as aldosterone antagonist, competitive aldosterone antagonist الابليرينون والاكتف ميتابولايت of spironolactone هو الكانرينون, which is also antagonist of aldosterone action. It is spironolactone or الالدكتون الاسم التجاري إلى induce hepatic cytochrome B450 and act in the presence of exogenous or endogenous aldosterone. Act only in the presence of exogenous or endogenous aldosterone. لأنه شنو الميكانيزم مالته هو competition with aldosterone. If there is no aldosterone, there is no diuresis induced by this drugs, no benefit from using of spironolactone. It is lead to decrease potassium excretion, yes, as we say, بمعنى أن هنا نذكر أنه when there is no significant level, circulatory level of aldosterone as occur in the primary adrenal insufficiency, which is called Addison disease, there is no diuresis induced by using of spironolactone. So we need it for exogenous aldosterone for its action. In Addison disease, primary adrenal insufficiency, there is no significant circulatory level of what? Aldosterone, as you know from physiology. In Addison disease, there is a primary adrenal insufficiency. And here, the spironolactone not act in the presence, not act or only act in the presence of exogenous or endogenous aldosterone. So if there is no absence of aldosterone in such a condition, Addison disease, there is no diuresis induced by, and there is no effect for this drugs. No benefit from using spironolactone by inducing diuresis in Addison disease. So it is mechanism of its action by competitive aldosterone antagonist lead to enhanced excretion sodium and conserving or retaining potassium and hydrogen. Clinical uses of spironolactone in combination in first indication is to combine with other natriuretic drugs اللي ذكرناها اللي سوينا هايبوكاليميا اللي هي الهاي efficacy diuretic والمودريت efficacy diuretic combined with the spironolactone in order to keep potassium and overcome hypokalemia associated with the high efficacy and moderate efficacy diuretic to control mild or hypertension for treatment hypertension. Whether it is severe hypertension with the loop diuretic and the spironolactone or moderate to mild hypertension with the third group. Number one. Number two, nephrotic syndrome, hepatic cirrhosis, refractory edema, doesn't respond to other drugs, and can be using also for hirsutism in female because spironolactone also has anti-androgenic effect. Anti-androgenic effect can be useful in the treatment hirsutism in females, abnormal hair growth. Side effect of spironolactone, abdominal pain, slight hyperuricemia, gynecomastia in male, and menstrual irregularity, especially amenorrhea in female. So it is effect on menstruation, in female, gynecomastia in male, and lead to, because of an anti-androgenic effect, may lead to gynecomastia in male with menstrual irregularity, especially amenorrhea in female. Abdominal pain with a slight hyperuricemia. Trimetrin, another low efficacy diuretics. Trimetrin from what with the amyloride acting by inhibit sodium renal sodium channels or block renal sodium channels. It is not a true aldosterone antagonist. Doesn't compete for receptor in distal convoluted tubule. It acts to retain potassium and excrete sodium, similar for action of what low efficacy spironolactone, but not compete with aldosterone. It only acts when diuretics are used with it that lead to sodium excretion, يعني natriuretic effect, or it is also act to the presence of excess amount of aldosterone, either by pretreatment or spontaneous production. بمعنى أنه natriuretic enhance excretion of the sodium, yes, and prevent reabsorption by renal tubule through what? A block sodium channel, renal sodium channel, block or inhibited, so there is no reabsorption for what? Excreted sodium in the renal tubule by natriuretic effect. Here, it is not a true aldosterone antagonist and doesn't compete for its receptor, but acts through inhibit renal sodium channels and by this inhibit reabsorption of sodium that excreted by natriuretic effect. Side effect, leg cramps in some patients can cause non-oliguric renal failure with indomethacin is used with it. Increase adverse effect of such drugs. Amiloride structurally related to the trimetry. The same effect أيضا نفس التأثير يكون هنا by inhibit or block sodium channels and usually combined with the thiazide in order to control potassium level to some extent. الثيازايد قلنا يمكن نسوي risk of hypokalemia more serious than the high efficacy, so combined with the amiloride or low efficacy diuretics اللي هي potassium sparing diuretics to control or to overcome hypokalemia, risk of hypokalemia. So high efficacy diuretics because excrete 15 to 20% of filtered load of sodium. Moderate efficacy diuretics represented by thiazide group has ability to excrete 5 to 10% of filtered load of sodium. Low efficacy with has ability to excrete only 5% of filtered load sodium with potassium sparing as we talking about it. High efficacy, all these three groups called natriuretic effect. That means has ability to excrete solute اللي ذكرناه اللي هو الصوديوم mainly with chloride and potassium as a serious adverse effect to it. Another group of diuretics represented by osmotic diuretics. This group of drugs differ from these first three groups, natriuretic effect. How? They are weak diuretic as mannitol, urea, sugar, site of action proximal, convoluted tubule, distal convoluted tubule, and collecting ducts. They are non-electrolyte substances, and that means they are freely filterable from glomeruli, undergo number 2, limited reabsorption in the renal tubule, and number 3, pharmacologically they are inert substances. They cause osmotic balance between the tubular fluid and peritubular fluid that limit backward movement of water, and in this way they lead to an increased volume of urine. بمعنى هنا increase osmolarity, increase the volume of urine, but without an increased excretion of sodium chloride or potassium, but only increase osmolar pressure of the tubular fluid more than peritubular or renal interstitial fluid, lead to backward movement of the water and increased volume of urine by this hyperosmolarity, because it is undergo limited reabsorption by renal tubule and freely filterable from glomeruli. Pharmacologically, inner substances increase only what? Osmotic pressure inside tubular fluid more than peritubular fluid or renal interstitial fluid, lead to backward movement of water from them and lead to what? An increased volume of urine by this mechanism. It is not absorbed orally, given intravenously in high doses from 50 to 200 milligram, indicated in case of oliguria to avoid acute renal failure. While the Karnaha indication with the high efficacy diuretic can be used for treatment as prophylaxis in oliguric cases to prevent develop acute renal failure. If field or can be added المانيتول هنا but not limited المانيتول for such condition if in the presence of high efficacy diuretics. So the first indication as prophylaxis in oliguric cases to avoid development acute renal failure. Number one. Number two, eliminate some drug toxicity that are reabsorbed by from renal tubule. For example, aspirin, salicylate, barbiturate, bromides, and other drugs that can be reabsorbed by renal tubule and increase the toxicity can be eliminated by mannitol. Number three, for reduce intracranial and intraocular pressure when there is road traffic accident with an increased intracranial pressure, intraocular pressure, mannitol can be giving intravenous infusion for reduction intracranial and intraocular pressure. Rarely use a resistant edema. Rarely use a resistant edema mannitol. Because why? Because it is, as we said in beginning, weak diuretics. Weak diuretics. Side effect of expansion volume of extracellular fluid. Expansion volume of extracellular fluid. For this reason, and dehydration from enhanced increased volume of urine. For this reason, because expansion volume of extracellular fluid, contraindication, congestive heart failure, pulmonary edema, lead to worsening their condition by increasing expansion volume of extracellular fluid. Another group, number 5, carbonic anhydrase inhibitor اللي طينا هنت عليها بداية محاضرتنا والمودريت efficacy diuretic قلنا related thiazide group structurally to the sulfonamide with has ability for carbonic anhydrase inhibitor. The carbonic anhydrase inhibitors, the chemically sulfonamide, considered as a moderate acting diuretics. Site of action, distal convoluted tubule and slightly affected proximal convoluted tubule. According to this equation, carbon dioxide plus water عن طريق carbonic anhydrase lead a reverse reaction to produce hydrogen ion plus bicarbonate SiO3. So by inhibit, this reaction is catalyzed by enzyme carbonic anhydrase. So by using inhibitors for carbonic anhydrase result in less production of hydrogen ion, which is important for sodium and bicarbonate reabsorption and potassium excretion. There is an increase in the inhibition of this such enzyme lead to an increased sodium bicarbonate in the urine, and because less hydrogen is available for exchange with sodium. So there is an increased volume of urine and there is metabolic acidosis because of bicarbonate, because loss of bicarbonate. يعني إذا صار inhibition for this enzyme carbonic anhydrase lead to decrease in hydrogen ion availability, which is important for reabsorption of sodium bicarbonate, lead to an increased excretion them in urine with potassium sparing. Yes, lead to an increased excretion of sodium bicarbonate in the urine, and this lead to loss of sodium as a diuretic, considered moderate diuretic effect, with what loss of bicarbonate lead to metabolic acidosis. While adverse effect in metabolic alkalosis associated with the high efficacy diuretic due to loss of chloride more than bicarbonate, as we see. Acidosis. For example, on the carbonic anhydrase inhibitor acetazolamide or ethoxazolamide. Acetazolamide, ethoxazolamide as examples for carbonic anhydrase inhibitor. The fifth group of diuretic, which is considered moderate efficacy diuretic, site of the action on the distal convoluted tubule and the proximal convoluted tubule. Through inhibition of carbonic anhydrase enzyme lead to decrease availability of the hydrogen ion which is important for reabsorption of sodium bicarbonate, lead to loss of them in urine and increase excretion of sodium with bicarbonate, lead to metabolic acidosis. Cetazolamide, ethoxazolamide, carbonic anhydrase inhibitor, indicated for treatment as diuretics, moderate efficacy diuretic number 1. Number 2, in glaucoma, when there is excess bicarbonate in the aqueous humor. So by decrease production of bicarbonate, lead to decrease production of aqueous humor, and this will lead to decrease intraocular pressure. So useful for treatment of glaucoma. In the epilepsy, also by unknown mechanism, carbonic anhydrase can be useful in the treatment tonic-clonic epilepsy, grand mal, absence type اللي هي البتت mal, and partial types of epilepsy. These three major indications for carbonic anhydrase as a diuretics: glaucoma, to decrease intracranial pressure, intraocular pressure by reduction in bicarbonate production in aqueous humor, and in epilepsy. Side effect: renal calculi, paresthesia, especially calcium type, paresthesia and numbness أيضا in toes and fingers, metabolic acidosis as we see, hepatic coma in patient with hepatic failure, infusing of them. This is the fifth diuretic drugs. There is some also minor diuretics represent or presence in the social drinking like tea, coffee, represented by xanthine, caffeine, theophylline. They are weak diuretic present in social drinks. Sites of their action in the distal convoluted tube. شكرا لكم.